Good afternoon, everyone. Please rise. Welcome to the Cade Museum for this May 2nd meeting of the Rotary Club of Gainesville. My name is Tom Collette, your Sergeant at Arms. Please silence your cell phones. Guests and Rotarians visiting us virtually on Zoom today, identify yourself in the chat. And if you're watching this after the fact on YouTube, please send us an email, info@rotarygainesville.org. We begin our meeting today with three things: joke, a song, and the Pledge of Allegiance. And here to kick us off for the meeting today, please welcome once again to the microphone, Pete Enwall.
Right. Wow. What a beautiful day it is. Golly, man. Can't hear me. Okay. What a beautiful day it is. Buddy Goodman gave me some observations I'd like to share with you about politics in general, politicians. And so Jay Leno said that if God wanted us to vote, he would have given us candidates to vote for. I'm just quoting. I didn't make these up. Clarence Barrow said, and this is 100 years ago, "When I was a boy, I was told that anybody could become president. And now I'm beginning to believe it." 100 years ago. Nothing's changed, I guess. And finally, we'd all like to vote for the best man, but somehow he's never a candidate, or she's never a candidate. Okay, we're gonna sing. I know it's a bitter. The truth is bittersweet sometimes. We're gonna sing "God Bless America." God bless America, land that I love. Stand beside her and guide her through the night with the light from above. From the mountains to the prairies, to the oceans white with foam. God bless America, my home, sweet home. God bless America, my home, sweet home. Join me in pledging allegiance to our flag. I pledge allegiance to the flag of the United States of America and to the republic which stands, one nation, under God, indivisible, with liberty and justice for all. Here's Laurie Vidal to give a prayer and to pray for my jokes.
Well, I do have two notes to mention before we pray. One very enjoyable and exciting, and one not a grief note. So last Tuesday, Craig and Michelle Carter added 2 children to their family, and they have adopted River, who is 13 years old, and Esme, 12 years old. And so in their getting close to retirement, they have added two beautiful young ladies to their lives, and it's quite a story, and it's a real blessing what Craig and Michelle have done. Also, I think that most of you probably have heard that Frank Sayre did pass away on Wednesday, and so please do be remembering Frank and Penny and the family. So let's join our hearts together as we pray. It is with heavy hearts today that we acknowledge the loss of Frank Sayre, fellow Rotarian and good friend for so many of us. We pray for those close to Frank, especially Penny, as they process the loss of a family member, a friend, during these days. In the midst of our sensing the loss, the impact of this loss, make us thankful for your sustaining grace through our daily lives, blessed with health and provision for life. We do so often take for granted the blessings so many of us have. Move us in our spirit of thanksgiving to a fresh commitment to service above self, to building goodwill and better friendships as we move about in this community. Thank you for this opportunity today to literally think through how we can guard our hearts through recent advancements in cardiovascular management. We are certainly so thankful for the many health professionals we are blessed with in this community. I pray in your most holy name. Amen.
Thank you, Lori. You may be seated unless you're visiting us today. And if you're one of our members who has a guest, please remain standing with that guest. The handsome Jason Shank has the microphone, bringing that to you.
Thank you. Very kind of you.
Thank you, Jason. Hello, today my guest is Judith Banks, a retired physician in the community and a good friend of Joe Coughlin and mine. Thank you.
Well, I'm here with my good friend, Carl. Carl and I has been friends for a while now, and we met also in Quarterback Club. So we believe in what you give and receive. He invited me to Quarterback Club, and I'm a member. He is visiting us today, and he knows some of you. So Carl, thank you for being here.
All of our visitors? Okay, thank you. We do have some announcements. Jacob, you should have just stayed standing up because you have our announcement today. Please welcome to the podium to speak to us now with an announcement, Jacob Atem.
Well, good afternoon, fellow Rotarian. If you're new, my name is Jacob Atem. I've been a Rotarian for a little bit of over 2 years in this club. I just want to tell you about the unfortunate event that is happening in Sudan. There's a lot of confusion. So I'm one of the lost boys of Sudan, left the war and became an orphan. In 2011, the Sudan divided into two. There's North Sudan, which is now Sudan, then there's South Sudan, where I'm from. And South Sudan is independent. Early April, unfortunately, the fighting started in Khartoum, which displaced a lot of people. South Sudan has been affected by flooding in 4 years, so a lot of people were flee to Khartoum. So there's over 2 million South Sudanese refugees in Khartoum. And then when this happened, these people now are stranded between the border to come back to South Sudan. And so keep the people in Sudan in your prayer and thoughts. It's a war now of fighting these two generals who want to control what, but pray for the women and children who are lacking basic medicine. And so we've been in communication with our district, in which our president, Greg, will mention later for some of you who want to be involved. But we also been called by the Ministry of Health to respond. One of our organization pillars is emergency response. So keep the people of North Sudan in your prayers, and thank you. And I just want to say how proud I am to be part of this Rotary Club. I never get a chance to say this, and I tell Greg, I am proud. The thing, you wouldn't believe the thing you do here locally and you do to the places in South Sudan. Recently, you guys have heard the Rotary District grant that we just implemented. What is happening, these people are coming from Khartoum, the capital city. In fact, the two target areas they're coming is where we were working in Mangala, because that's a more safer, and Juba. And so indirectly, we have a lot of influx of these refugees that we're trying to help. So thank you, and you will hear more from our president, Greg. Thank you so much.
Thank you very much, Jacob. It is the first Tuesday in a new month, so it's time for us to recognize and take money from those celebrating a birthday in May. If we call your name as one of those celebrating your birthday this month, please bring that dollar or more. To Greg Young, here are our birthdays for the month of May. Celebrated her birthday yesterday, Marcia Eubank. Lisa Mueller, Buddy Irby, Doug Wilcox, Ryan Kremser, Dominic Scorpio, Marianne Westpaul, Harry Shaw, Nancy Hart, Wesley Eubank, later this month, John Coker, Shane McIntosh, Don Robertson, Michael Conroy, Bill Stasowitz. Woohoo! Come on, there we go. I knew we'd get one out of him. Tom Summers, Jolene Miller. Also, we like to commemorate member anniversaries during this month. Jason Shank, 17 years ago, joined the club. Not here today, but joining 19 years ago. Grace Horvath, looks like one other notable. Matthew Brady joined 8 years ago. But the most notable of those who we recognize today joined 35 years ago. Now he's back to sing happy birthday, Pete Enwall.
Okay. Gusto, ready? Happy birthday to you. Happy birthday to you. Happy birthday, fellow Rotarians. Happy birthday to you. You got it.
Let's keep on moving on and turn the meeting over to your president, Greg Young. It's all yours, sir.
Thanks, Tom. Greetings all. I'm so glad you could be here to join us for today's meeting. I want to thank Jacob for sharing that update. I wanted to make it clear to the club that there's separate entities and countries, and the work we did with our district grant is going to South Sudan, which will help some of the refugees coming out of North Sudan. So thank you, Jacob, for leading that. Yesterday, District Governor announced a call to action for individuals and clubs that want to help with that crisis that's going on over there, humanitarian crisis. Donations to the York Foundation to help refugees that are moving to South Sudan. I can provide more information on that later, so let's keep in touch on that. In other district news, we have a grant that was finalized by our district, part of a big grant to go to the victims of the Turkey earthquakes, and so $183,000 is the total grant from other districts around our region, and so that's good news going there to help. Reminder, the District Assembly and Conference is just 10 days away. It'll be held on Friday, May 12th and the 13th, Flagler College in St. Augustine. Registration prices start going up this Friday, so if you want to go over there and join me and other Rotarians, please sign up or ask me if you have any questions. Lastly, we hope to see you tomorrow at 5 p.m. at the Lawn Bar. It's located right across the street at South Main Station, near Hartwood, if any of you have been there. Please see details in the bulletin. And now, I'd like to bring up to the lectern our program chair, Joe Coffin, to introduce today's program.
The speaker today is truly distinguished, and he's worried about all of your hearts. I first met him when a new drug was prescribed for me 7 years ago, and my attending cardiologist said, I don't know, that's too new. Let's go ask Art Lee. He's here today. So for 7 years, he's known what he's going to tell you about today, new drugs that will reduce your chance of heart attack and stroke by 20%. University of Pennsylvania cum laude graduate, Dr. Lee, New York City, Mount Sinai Medical School, cardiology residency, and fellowship in interventional radiology. interventional cardiology. That means he can take pictures of the blood vessels of the inside of your heart to start with. He has board certification, which is national recognition in internal medicine, nuclear cardiology, echocardiology, how to study the heart with sound waves, and last of all, interventional cardiology. His training allows him to do something about the problems that are found when you have symptoms of heart problems. Art will take it over from here to parting words. He's a great physician, and he's a great person. Art. Lee.
All right, thank you for the kind words, Joe. I appreciate it. So, honored to be here with you guys today. So Art Lee, interventional cardiologist, saving hearts, but also legs. So preventing amputation is one of my big passions. But I've been saying for a long time that I'm an interventional cardiologist, which implies that I fix things, I put stents in, I open blockages, and so on and so forth. But intervention really means coming between something and its outcome, changing the outcome of events, right? And so I feel a lot of times these days, in the last 7 years really, that I do more in the office visit, that 15-minute office visit, by putting the patient on the right medications, talking about certain things, than I do in the cath lab. And I really mean that. When I put a stent in the cath lab, most of the time I'm not changing that patient's course of events, meaning heart attacks, reducing heart attacks, or making them live longer. But if I start the right medications in the office, I am making that change. So I really believe in that. And so I'm a very aggressive secondary prevention cardiologist as well, okay? So we'll get my slides up. So I'm gonna look this way. So we're gonna talk about some medical advances over the last 5 to 7 years. So a couple things. I could tell you cardiovascular disease, okay, is the #1 killer, and you can put whatever you want after that. In the US, in the world, among men, among women, even in 2020, in the year of COVID, it was the #1 killer, okay? And so other ways to put it, every 40 seconds, somebody has an MI or stroke in the US, okay? It's an extremely high disease state, high-risk disease state. So once you've had a heart attack, the patients, 1 in 5 will have another cardiac event within 1 year. The highest risk is within the first year or two. Now, as that settles down, the risk is still extremely high. So it depends on what you count in it, but we're talking about 5% per year, sometimes up to 10% per year of having another event. So if you include another stent, being hospitalized for unstable angina, stroke, heart attack, and dying, it's about 10% per year. It's high. It may not sound as high, but if you talk about a 60-year-old person, by the time they're 70, they basically have almost 100% chance of having another event, despite doing everything that we tell them to do, okay? Changing their lifestyle, taking the right medications, so on and so forth. So we still haven't figured it out completely. And again, coronary disease is probably the most well-known. So atherosclerotic disease is cholesterol plaque buildup in the heart arteries, okay? But it's a systemic process. It's very rare that you have it here and you don't have it in other places. So peripheral arterial disease is basically anywhere else in the body. Stroke is typically in the brain, okay? If you look here in, what is that, magenta and then purple, despite doing everything, patients, that we follow guidelines to the best that we can, from year 1 to year 3, you see the risk doubles. And these are large registries, global registries that they're looking at. And you see peripheral arterial disease is actually a higher risk. It's always higher risk. People think that a blockage in the leg is not as bad as a blockage in the heart, but it's actually worse, typically. Okay? These are the same patients who are typically cardiac patients, but you can see very high limb events, so major amputation about 4%, or needing a revascularization, a roto-rooter, or a stent in the lower extremities, almost 20% at 4 years. Polyvascular disease, so again, typically a systemic disease, but clinically, a patient could have a heart attack, they could have a stroke, they could have, a blockage in the leg that we have to open, but you can also have multiple, right? You can have 2 of the 3 or 3 of the 3. That's called polyvascular disease, multiple beds. And you see that if you have polyvascular disease, your risk of all the bad events is higher as well. Diabetes, so there's an epidemic of diabetes now. We've come a long way in the last 30 to 40 years. You can see the cardiovascular death in red in diabetics, okay, versus the general population without diabetes. And there's some studies in the bottom, landmark trials in the bottom, where we learned about the benefits of statins, ACE inhibitors. And so that gap has closed, but you still have, you see here, 40%, and today probably at least 20% increased risk of dying if you just have diabetes. You can see diabetes increases your risk of heart attack, stroke, needing stents 4 to 5 times. Also increases your risk of heart failure. Heart failure is a very common problem. A lot of hospitalizations for it, and a big cost to the healthcare system. And so here you can see if you have diabetes, you on average live 6 years less than the people who don't have diabetes. But if you have diabetes and a stroke or MI, typically you're talking about 13 years reduced life expectancy. So it's a bad combination. Okay, so this is like the crux of understanding this disease. This is a schematic of a blood vessel, okay, cut through. And the blood is coming down the tube, you know, to go where it needs to go. On the bottom is a cholesterol plaque, okay? These are basically cholesterol that's been shoveled underneath the endothelium, the lining of the blood cell, or the blood vessel, oxidizing and forms a lesion there, okay? These have been found actually as young as 2 years of age. So it starts at a very young age. You know, in autopsy studies, they found it in 2-year-olds. Over a lifetime, you get these, and they can be, so what I tell patients is think about this like a pimple, okay? You can have a pimple that's really angry, red, about to pop, very thin-walled, you know, irritated. That happens if your diabetes is out of control, you're a smoker, you know, et cetera, et cetera. Versus you can have a plaque that's there very, very stably, like a blackhead that doesn't really going to go anywhere unless you really do something to it. And so these plaques, you know, reside in a lot of us. And at some point when they pop, okay, when they ulcerate or erode, you have an injury to the vessel wall. So your body's natural defenses are to heal that ulceration, that pimple that popped. And so you get a blood clot, that's what you see here in red and blue and green, onto that ulcer to heal it. Okay, so when that happens, that clot can be big, small, but remember, these vessels are typically 2 to 3 millimeters, so there's not a lot of room there, okay? So these are things that we focus on a lot. We're gonna talk about really 2 main medicines. I put a third and a fourth in there if we have time, but one is to stabilize the plaque, so that plaque doesn't grow as fast and doesn't erode and rupture, okay? And the second is when they do rupture, how do we prevent the clot from being too big? One of the things we do is aspirin, right? Data's been around for many, many years, obviously, many decades. It does reduce the event rate by about 20% by itself. Aspirin is making that clot smaller. It works on the platelets, okay? But there are other components of that clot as well. So typically, when you have a clinical event, all the bad events that we don't want to have or want our friends to have or family to have, it's typically brought on by an atherothrombotic event. Okay, athero is the cholesterol plaque, thrombotic is a blood clot. So it's a combination where the clot the plaque ruptures and the clot forms on it. So if you have it in anywhere in the brain or the carotid arteries, you get a stroke. If you have it in the carotid bed and the coronary bed, you have a heart attack. If you have it in the peripheral space, you can have acute limb ischemia, sudden cold leg, which is a very high risk of amputation and dying, okay? So these are all bad things, bad combinations to have. Now, we talk about risk factors, and we kind of generally categorize them. You know, there's certain things you can't control. Aging. You can't control aging. You can't control your family history. Modifiable lifestyle, so diet, exercise, you know, the right weight, not smoking. Those kind of things are lifestyle modifications that are very, very important. And then modifiable conditions on the left, you know, dealing with blood pressure, diabetes control, cholesterol management. Those are the modifiable factors that we can do with lifestyle, but also with pharmaceutical agents. And so, again, broad categories of things that we can work on historically. So when they looked at, this is called Interheart, when they looked at a bunch of patients that had a heart attack, and they teased apart their risk factors, and they said, what was the most contributing factor to this person's heart attack? And again, it's statisticians that are doing this, but they have the typical risk factors on the bottom: diabetes, lack of exercise, hypertension, smoking, et cetera, et cetera. It's still high cholesterol. A high lipid level was the biggest predictor of having an MI. MI is a heart attack, okay? Myocardial infarction. Data that, again, is now 20 years old shows that, you know, from the first studies up here, 4S, coming all the way down, as we got more and more aggressive with cholesterol, you see a linear relationship between the event rate, so having heart attacks and strokes, versus your cholesterol on the bottom. The lower the cholesterol goes, the lower your event rate. And now we have a new class of medications called PCSK9 inhibitors, which we'll talk about, that can get you literally down to zero. Okay, and that curve, as I'll show you later, continues to go down linearly. There's no attenuation of effect, so no loss of effect, and there's no harm. There's no such thing as too low anymore for cholesterol. So we're going to talk about Repatha. Repatha is just one of the brand names of, and I think the best in class for PCSK9 inhibitors. It is indicated for people who've had an event to reduce the risk of heart attack, stroke, and needing another stent. So very quickly, this may be too much, but this is just how it works. Repatha is in red. Your receptor in the to grab LDL is on your liver cells, okay? And what happens is the cholesterol's coming in the bloodstream. Let's see. Your receptor grabs onto the cholesterol, brings it into the cell, breaks it up into the building blocks that you need for exercise and all these other things, okay? What happens though, there's something called PCSK9 that randomly, when it binds, that receptor gets destroyed as well. It doesn't recycle anymore. So Repatha binds the PCSK9 so the receptor can recycle many more times before being destroyed. And that's how the drug works, okay? I was an early adopter, like you said, 7 years ago, because it was interesting how this drug was developed. What they did is scientists took blood from anybody, okay? And there was a cluster of patients in Texas that had very low cholesterol, LDLs of like 9, 13. They studied these patients and they said, wow, they're living normal lives. They're not demented, they're not depressed, they're holding jobs, they're having kids, but they have 90% less cardiovascular morbidity than the general population, okay? They also found a family in France that had the opposite, okay? High cholesterol, very high event rates, and when they sequenced their DNA, they found the PCSK9 was what was different. One family had none, one family had a lot. So that's where they developed this molecule and this antibody to it. And again, I was an early adopter because I know that there are people potentially in the audience that have no PCSK9 and they're doing well. So again, large study, over 27,000 patients, very well treated, okay? Most of these patients were on lipid-lowering therapy, 99%, and actually 70% were on what we call high-intensity statins, okay? So 2 top doses of the 2 strongest statins. And, you know, Repatha drops your LDL dramatically by over 60%, okay? Very reliably. And what I'll show you here is 84% of patients had an LDL less than 55. The average LDL in the Repatha arm was 26. Okay, so we went from 90 to 26 with the Repatha. Despite that, if you look at the side effects, and most of the time, you know, if you look at side effects of statins and all the other things, there's gonna be a difference, okay? Muscle aches and so on and so forth. I've brought this up many times in the office visits. I want patients to expect a good experience. There's literally no difference in side effects when you look at placebo versus Repatha. We're talking about decimal points of percent, nothing that jumps out. There's no drug-drug interactions. It's a very safe drug. And so what did we see? So you see here the curves basically separating. Now, what's interesting, in red is the Repatha, okay, and that's what you want to see, lower event rates. But what's interesting is that it took 9 months before the curves separate. And that's what we typically see. For a plaque-modifying drug, it takes time for the contents of the plaque to change and become more stable. So it does nothing for 9 months, and then 9 months the curves start to separate, so that by 2.2 years, you have a dramatic separation. And again, it will continue, probably. They stopped the trial there. Now, it was driven by reduction of heart attack, stroke, and stents. They did do an extension trial, okay, where they took both groups of patients and they gave them both the medicine. So remember, one group doesn't have the medicine, the other group has the medicine. After the 2.2 years, they put both groups on the medicine, mainly to look for side effects. But what they found, I'll show you this curve again. So this is the extension of the curve. If you look at the data, it goes all the way down to 0, and you keep getting lower and lower event rates. So again, if you've had a heart attack, stroke, or anything in your legs, lower is better, literally down to 0, okay? This is the open label long-term extension trial. And I think what's interesting here is you see the red is the people who were on it and continued on it. The blue is or dark blue is the people who didn't have it. They were on placebo. And then after the trial was ended, they were given the real drug, and you can see they come right down to the other group, okay? But despite this, and because of the delay, the 2.2 years of delay in getting Repatha, you see the curves still separate, okay? Heart attack, stroke, and dying, you can see the people who didn't get it for the first 2 years continue to not do as well. There may be some closing of the gap in the last year, but there is a legacy effect of that trial. So again, what I'm trying to say is that the earlier you get your cholesterol down in life in general, the better, especially after a cardiac event. And this is mortality. We see a mortality difference in that the patients who didn't get it early also were dying at a higher rate than the patients who had it the whole time. So anyway, the guidelines over the last 15 years have continually evolved where we were, okay, we want to get it under 160, then under 130. This is the bad cholesterol, LDL. Then under 100, then under 70. And the most recent revision, which just happened 3 months ago, is now recommending less than 55 for anybody who's had a heart attack or any disease, okay? So again, the guidelines are continuing to follow the data as the bottom line. So that's the miracle of Repatha and PCSK9 inhibitors, okay? And that's really to stabilize the plaque. And remember this plaque picture, right? One other thing that they've done is imaging, coronary imaging. When we do stents, we can put a little camera, basically ultrasound beam, down the artery and look at the artery, and you get these high resolution images of the wall of the artery and the plaque. And so what they found when people who had a heart attack and then were put on Repatha versus regular statins, 1 year later they came back and they imaged them again, and the fibrous cap, remember I told you it's like a pimple, right? We want the cap to be very thick so it doesn't pop. The cap got much thicker than patients who were not on Repatha, implying stability of that plaque, okay? That plaque is not gonna bother you if it doesn't grow, block the artery, or pop. And so again, this is really good data showing that that's why it stabilizes. One thing I didn't put in here is that they also looked at the lipid core, all the fatty material inside the plaque, and that also shrank over the year, okay? So those are the things that we see happening with aggressive LDL lowering with Repatha. And then what's staggering is you would hope that your physician is checking the cholesterol, okay, and making recommendations. But if you look at the statistics, this is in nationally, and this is in our area, 70% of patients do not ever get an LDL test. You can see it broken down by months, but 70% never even get an LDL test, okay? And I can tell you that in our practice, going back 10 years, we were sort of guilty of this because back then, a lot of primary care doctors managed the cholesterol, okay? Not until Repatha came on the scene that we really needed to get involved because it was harder to get approved is when we started looking at it. And so now when I do talks, I really advocate this should be part of your normal, follow-up labs, but also especially if you're gonna have a procedure, not only do you need a CBC and a basic metabolic panel, but you should have a cholesterol panel. The more we see it, the more likely we're gonna act on it is the bottom line. So definitely, be your own best advocate and make sure you have something like this and it's looked at and discussed with your physician. This is just a busy slide, but just showing that, again, 37% of patients aren't even treated with any sort of lipid-lowering therapy despite having a recent heart attack, within 3 months. All right, so going back to this, let's talk about the other component. And again, I don't know how I'm doing on time, but I promise I won't go over. The clot is made of a platelet on the right and a coagulation cascade on the left, okay? It's not just a platelet or just that, it's a combination of the two. And so with Xarelto, who has the best data, Xarelto has a lot of indications from AFib, blood clots in the lungs, so on and so forth, down to this indication. And so the doses that we give for AFib and blood clots in the lungs are anywhere from 20 to 30 milligrams a day. But what they studied was just 2.5 milligrams twice a day, okay, with a baby aspirin. I'll skip these is the bottom line, but there's reasons why they studied this because aspirin, Plavix, you guys probably heard of Plavix, stuff like that, medications like that do not deal with thrombin. They only deal with platelets, okay? So this is the first combination that deals with thrombin and platelets, which is what the clot is made up of. And this is a graph just showing you that, when you put someone on aspirin and Plavix on the left, you don't inhibit thrombin. Only when you add Xarelto do you drop the thrombin levels, which is part of that clot. Again, very large trial, 27,000 plus patients. And here you see a very nice curve. If you're the drug maker, this is what you want to see. You see in purple with treatment of Xarelto, your event rates are much, much less. What's different here is, remember before, 9 months, nothing happened. The lines are on top of each other. But here, right away, there's separation, which makes sense, right? Because how is this working? This is when your plaque ruptures and you have a clot on it. And unfortunately, somebody here, one of us could have a plaque rupture, right? Hopefully, we don't even know what happens. We go home, go on with our lives, you have a little clot there and it heals. But sometimes it becomes clinically significant, you end up in the hospital. Here, as soon as you start the drug, you're making that clot smaller. Okay, so that's why the curves start to separate right away and get bigger and bigger. And this trial was actually stopped early. Under 2 years of treatment, they stopped it because of overwhelming efficacy. You can see the big difference. What drove the endpoint was a dramatic reduction in stroke by 42%, death by 22%, and heart attack by 14%. There was also significant benefit, well, there's all-cause mortality, so just dying for any reason, but there's also significant benefit. It didn't matter if you were heart disease or peripheral arterial disease in legs. Acute limb ischemia, which is a bad disease, because again, if you have acute limb ischemia, you're typically in the hospital, having multiple procedures, in the ICU, getting TPA, so it's a clot melting drug that can cause you to bleed in all kinds of places. And major amputation, you can see a 70% reduction in major amputation. This is one of the reasons that the VA adopted this drug into their pathways within 4 months of approval. And again, the VA is typically not an early adopter. They don't want to, pay for expensive therapies and drugs. They usually wait and drag it out. But because of the amputations in veterans, they introduced this into their pathway within 4 months of approval. Okay, so how much time? Enough? Okay. Okay, real quick. Those are the two classes of medicines that I showed you with the plaque rupture, okay? There are other drugs that we don't exactly know how they work, but they have dramatic results, okay? So something called Jardiance. You guys have seen the commercials here too, okay? It started off as a diabetes drug, okay? I've been saying for a couple of years, this is really a cardiac drug with a side effect of lowering your sugar, and it's really come to fruition. So all the approved indications now are here, lowering sugar. When you have a diabetic, show it, I think it's here, yeah. If you have diabetes and heart disease and you get on Jardiance, you live an extra 1 to 5 years, okay? Nobody knows exactly why it happens, but the separation is pretty dramatic. Right away it separates. 38% reduction in cardiovascular death, okay? Most of the death is sudden cardiac death, just dropping dead, so probably arrhythmias. So that was about 5 years ago, 6 years ago, and that's when I was really excited. I went back and got very comfortable with the space, with the diabetes, because again, as cardiologists, diabetes is overwhelming with all the advancements, but now very comfortable with it and trying to get all my colleagues to be comfortable with it. And it's gotten a little easier. So again, very dramatic results. You only need to treat 46 patients in 3 years to prevent the death. It's gotten a little easier because when they looked at that trial, they realized, why are these patients having less heart failure? Okay, so they did a heart failure study. And again, heart failure is also a really bad disease state. You can see the curves separate massively here. You only need to treat 19 patients in less than a year and a half to make a difference with heart failure. So this drug is like what we call a pleiotropic drug, has multiple effects beyond what we understand. Lower sugar, can make you live longer, can prevent heart failure hospitalizations, and now the newest data is protect your kidneys, slow down kidney, needing dialysis. So really, really amazing class of drugs. I don't have diabetes and I take this drug as a vitamin. And again, that's just one hospital, the first hospitalization. If you take all the hospitalizations for heart failure, you can see the curves get even more dramatically increased. So preventing the second, third, and fourth. All right, and then the last thing, just because fish oil is something a lot of people take. So fish oil doesn't have a lot of good data, and I really recommend against taking over-the-counter fish oils because there can be a lot of contamination. There can be harmful ingredients in there. There can be oxidized LDL in there, and even the prescribed one, we have choice of two. One of them does nothing. There's no outcomes data, but the one that does have is Vasipa, which has dramatic results. Now, it is one trial. It has not been replicated. Is the only reason that I'm maybe a little less, excited, but it is pretty dramatic results. And so this is a medication that, again, lowers heart attack, stroke, dying. You can see very, very big numbers here. So that is another therapy that can be, discussed with your physician, especially if you have triglycerides that are over 150 and you've had an event. All right, so in conclusion, coronary disease, peripheral arterial disease are extremely high risk disease states. We as physicians need to stay up to date on the best medical and interventional therapies to drive new standards of care and not be satisfied with clinical inertia, okay? Don't think that if your physician doesn't bring it up with you, that it means you don't need it, okay? I have partners still that I need to, convince, look at the data and let's start talking about this. Clinical inertia is not a good thing, especially when, some of the stuff I showed you, as soon as you start Jardiance, for example, by day 12, there's already a significant difference in outcomes, okay? I put here because I'm a big proponent of limb salvage. So again, promoting limb salvage awareness amongst the community is really, really important. Medical therapy should not be an afterthought, okay? It is a vital part of the intervention. Unfortunately, unfortunately, I have a lot of colleagues who just want to put stents in all day, and then after they don't really want to, see the patient as often as I think they should, or do all the other stuff, treat the patient as a whole. They want to just go in and put stents in. So to me, medical therapy is not an afterthought. It should be part of the intervention. And again, I think the definition of best medical therapy is rapidly evolving, especially over the last 7 years, and needs to be evaluated at every encounter with every patient annually. Okay. All right. Thank you very much. I know that was a lot, but I'm happy to take any questions or.
Thank you. You had mentioned the first medication is beneficial for those who have had a history of heart attack or stroke. Would you recommend Xarelto and Jardiance for those who have those higher likelihoods of getting a stroke, or like Crestor or something?
So the reason that all of these studies that I showed you and indications are for secondary prevention, meaning in people who've had an event, is because their event rates are so high. So it would cost these companies multiple times more money to study it in primary prevention. So patients who haven't had an event, now there have been some that have been done, but again, if you haven't had an event, you're you need a lot more patients, and you're going to have to study them for like 10 or 15 years. So that's why those studies aren't frequently done. Now, we have some data with statins, because statins became generic and so on and so forth. So they did do things like Air Force. They did study on Air Force pilots, for example. So we do know that in primary prevention, if you lower your cholesterol, you will prevent events as well. Unfortunately, with these other medications, they're so new, nobody's doing those studies in primary prevention. Now, if you could get it approved, then yes, I think that there's advantages to using those drugs. I'll tell you, for example, calcium score is a test that you can get. It's a non-invasive test. It's a CAT scan, just seeing if you have any calcium in the arteries. If you have a calcium score, even if it's 2, you have subclinical coronary disease. So in those patients, I will try to get them on Repatha and these drugs potentially, and try to get it approved. If they get it approved, it's good, because you're catching the disease at a very early stage in the curve, almost primary prevention, because they haven't had a heart attack. But yeah, I would definitely try to get it. There's one scenario where you can get it without disease, and that's if you have very high cholesterol. So the familial type, where your LDL is typically over 190, and you have a family history of heart disease. So 190 is the number where we start thinking about that heterozygous FH patient. It's like 1 in 250 patients. Yeah.
Hi, I have a question about primary prevention, and just to clarify for everybody here, you were mostly talking about secondary prevention.
Exactly.
A huge and important topic, but I have a question about primary. And that is, a lot of people that are starting on statins for primary prevention are having these muscle pain things.
Yep.
How do you recommend people deal with that?
So if you look at the data, a lot of the muscle aches, and I was, I took a statin, and I almost took a statin. That's what it is. I almost started a statin, and then I had like some muscle aches. I was like, oh, if I had taken a statin, I would have blamed that on the muscle aches in general are just common, I think. If you look at the studies where they blinded patients, where they didn't know if they were taking a statin or placebo, the muscle aches were very similar, and they were about 25%. Whether you were on a fake pill or the real pill, it was about 25% reported muscle aches. So I think probably the complaint is overblown, but it's hard to argue with perception, right? So when they do have that, what I typically do is stop it. When it goes away, re-challenge and see if it comes back, okay? That's one possibility. The other possibility is to switch it from one, like if it's a Lipitor, change it to a Crestor, lower the dose, and they have different characteristics. One's lipophilic, one's lipophobic. And sometimes I'll drop the dose as low as possible. So Crestor, 5 milligrams every other day, stuff like that. If I think it's enough for that patient. There are other medications that are neuro, like Livalo is a neuro one that seems, if you don't tolerate the other one, sometimes you tolerate that one. So sometimes we rotate. The good thing nowadays is that there are a lot of other agents that we can use, some brand names, some generic. So you're still going to have some of the approval hurdles. But if you truly are statin intolerant, there are other agents that I didn't even bring up here. So bempedoic acid, Zetia. Zetia has been around forever. So Zetia will give you about a 15%, 18% reduction in LDL. So that's another drug, and it works in a totally different manner. So there are other agents that we can use. Obviously, the lifestyle modifications, weight loss can be a big factor. So diet, if you eat the worst, then you can go completely vegan. You can make a good reduction, maybe 25%. But weight loss is another one that can really dramatically change your lipid profile. So that's sort of what we do.
Got a Zoom question real quick, Jason. Kirk Klein asks, if someone is a long-term smoker and they quit, what happens? Is the damage done or does repair happen?
So definitely there's damage done typically if they're long-term smokers, but there is data showing that, and not just cardiac, but there's pretty immediate effects of quitting. Within 8 weeks, your ciliary cells and the airways start functioning better and getting the mucus out and so on and so forth. There's data showing preoperative risk decreases, even if you can stop smoking again for that few weeks before surgery. So I think there are immediate benefits, but there is unfortunately long-term damage that's still there and the risk. So we always take that into account.
And follow-up question to Dr. Hart's question about primary prevention. A lot of physicians, of course, now recommend as you age to take an aspirin, 81 milligrams per night or day. Would the same possibly be theoretically said for a low dose of any of these drugs you mentioned today?
Yeah, I mean, so I think in patients who are high risk, we still would recommend baby aspirin. There's some data that's been out the last few years that shows primary prevention in patients who are not high risk, the benefit is outweighed by the risk of bleeding. So unless someone has high risk or vascular disease, we typically don't. I would say in terms of the statins, there is data, like I said, in primary prevention that if and a target keeps moving, but if your cholesterol, the higher your cholesterol is, there's calculators you can download on the internet, on the App Store, cardiac risk calculators, that your long-term risk of a heart attack, lifetime risk is a certain number, but the lower your LDL is, the lower that is. So again, I think we aim for 100. We aim for LDL less than 100, and taking a low-dose statin, even at a younger age, to keep it under 100 versus 130, for example, will just decrease your lifetime risk of having an event. But it's all statistics. You never know, but it's statistics.
Thank you, doctor.
Thank you, guys.
I tried.
Thanks. Obviously, you're talking about a very interesting topic that we all care about very much, so thank you. And appreciate you taking the time out of your busy schedule. Thank you, Joe, for organizing that, because that's not always easy for a man this busy to get over to talk with us. In gratitude for you coming today, I'd like to give you this award signifying that we are making a donation to the Cade Museum Scholarship Foundation or Fund so that at-risk children can attend the Cade Museum and enjoy the services and the spark the wonder they provide. So thank you so much for coming today.
Thank you, everybody.
And Dr. Lee might be available after for questions. If you weren't able to get your question in during the meeting time, please see Dr. Lee afterwards. I think he said he might be available for a few questions. Let's see, where are we? We're so glad you came today and hope to see you next week. Our speaker will be actually the Rotary Speech Contest, Youth Speech Contest. Mike Conroy will lead that program. He'll be our host. And as a bit of housekeeping, there will be a big crane in this room next week. We will not have our meeting in this room. We are actually going to be on the back terrace if the river doesn't flood and the creek don't rise kind of thing. Hopefully we're going to be okay. But we tried to find a plan B, but couldn't get one. So anyway, with that said, quote of the day, healthy habits are your heart's desire. Unknown. And the Rotary Reading Safari Lucky Raffle ticket number, last 3 digits, 428. And with that, we're adjourned.